Good evening, everybody, and welcome to our session this evening on blood cancers. I'd firstly like to do an acknowledgement of country. The Northwestern Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging. Just some housekeeping for this evening before we get started. So all attendees are muted. Please keep your microphone on mute. Please ask questions via the question box or raise your hand. Questions and answers will be at the end of the presentation. Only presentation components of this session is being filmed. Any questions will be edited out to protect your privacy. So we have some upcoming education and training sessions, and this is under the Project Echo. And so these are some sessions relating to the after effects of patients who have been diagnosed with COVID-19. Some great sessions there. If you're interested in attending these sessions, please check out our website and register for these. We also have a couple of new health pathways on some of the optimal care pathways for cancer guidelines into health pathways. So please have a look at these great health pathways. And we also have a health pathway containing the acute myeloid leukemia, OCP, coming in at the end of November. We always welcome health professionals to register their interest in our think tank. So please, if you are interested in joining our think tank, and this is a great opportunity to get involved with the PHN. If you're interested, please give us a call or check out our website. We also have some consumer views of telehealth research project at the moment. General practice and allied health services are invited to participate in a research study to explore consumer views of telehealth use in primary care. The opportunity is open to services currently using the Health Direct platform within the Northwestern Melbourne PHN. So please, if you are interested in this project, please speak to Jessica at the PHN. There is an email address there and a phone number you can contact. We have a great opportunity at the moment on a quality improvement project on family violence. It's a great opportunity to be involved. There's many benefits for your practice. There's a small incentive there for $3,000 and some education as well. So a great quality improvement project that we are actually coordinating at the moment with general practice. We also have the expression of interest page that is available to register your interest as well. And we have Irina there, who also is the IQI project lead on the family violence project there. So great opportunity for general practice. So we have our presenters this evening. So our presenters this evening is Dr. Teresa Leung, Dr. Hai Yin Lim, Mr. Christopher Daniels and Ms. Tracy Webster. They will be all our speakers this evening. So I'll hand over to the first speaker this evening. Just also, these slides will be provided to all attendees at the end of this session in case you were interested in some of those projects or expressions of interest that you'd like to register for, etc. So I'll hand over to our presenters. Thank you.
All right, good evening, everyone. I trust you can see my slides, hopefully. although now I have to go back to my slides. Excellent. All right, so I'm Yin. I work with Teresa. So Teresa is the clever malignant specialist, whereas my interest is in thrombosis and research. So I'll be starting with probably about 20-25 minutes of talk on thrombosis. Please feel free to ask me any questions towards the end of the talk. So the objectives of this talk is really to talk about the management of the common VTE presentations and perhaps have some discussion surrounding anticoagulation in high-risk bleeding and thrombotic patients. So just as we are getting started, I would just like to talk a little bit about the terminology of VTE, because I think it's really something that is quite important. And having thrombosis as my special interest, it can be a little bit frustrating sometimes when you get a history from someone asking you whether the patient can stop anticoagulation, and you get a one sentence going, oh, this patient had a clot. So the question I would like to ask essentially is what type of clot the patient has, but importantly as well, it's not only the location of the clot that's important, it's actually whether it is provoked or unprovoked, because the reason why we want to know that is that it has a lot of implication on long-term management of this patient and whether this patient should remain on long-term anticoagulation. So probably the most common terminology you would have heard is provoked and unprovoked. But now in recent years, there is this third category of minimally provoked. So essentially, when it is a major provoking factor, such as surgery or very obvious immobility, for example, the patient's broken an ankle sort of thing, then it is very clearly provoked. And in this situation, generally, the risk of recurrence, a VTE recurrence at 5 years in this patient are minimal at about 3%. However, if the patient had a minimally provoked clot, and generally this is defined as a non-surgical transient risk factor such as travel. So, if the patient tells you, I've come back from an air flight travel, or the patients had a clot when they were pregnant or when they were on the pill or hormonal replacement therapy, then I'm quite concerned that this is actually, in fact, a minimally provoked clot and should not necessarily be treated similar to a majorly provoked clot. The risk of recurrence, as you can see on the screen, is 15% at 5 years, so it's not unsubstantial. And certainly unprovoked is the ones which you cannot find a reason why they've had a clot, and that's not uncommon either. That basically accounts for about 30% of the clot. But the risk of recurrence in this patient is also very significant at about 25 to 30% recurrence at 5 years. And then we also have probably a fourth category, which can call it provoked to a certain extent, but they are actually the cancer-associated clot, which has a higher risk of recurrence as long as they have cancer in situ. So we'll briefly discuss the case of Paul. So Paul is a 75-year-old gentleman who has recently been discharged from hospital following a left total hip replacement. Now, he had gone home as per protocol with 4 weeks of prophylactic Clexane and compression stockings. And he is now presented to your clinic with 2 weeks of left leg swelling. So bearing in mind that patients with total hip replacement often go home with 28 days of prophylactic Clexane, Paul's actually developed left leg swelling whilst he's on prophylactic Clexane. So then often the question that I would ask the attendees would be, what would you do next? So I guess given that this is a thrombosis talk, then essentially we will be looking for clots. But I mean, I guess in your practice, you would also be looking for other signs of infection or any signs of hip replacement issue. But for the purposes of this talk, I'll concentrate on the potential DVT. So then you look at Paul's leg, and Paul's got an uneven leg. Sorry, I just realized I've got a right leg that's swollen. I've got left to right disorientation, so forgive me, but Paul's basically got a unilateral leg swelling with a past history of DVT 20 years ago, which Paul is not able to tell me whether it was provoked or unprovoked, but all he could tell me was that he was on warfarin for 6 months and that was stopped. All right, And on physical examination, as you can see, it's self-evident. He does have a unilateral leg swelling. He's otherwise well, no fevers, no chest pain, no shortness of breath. So then the question then is, what do you do next? So I guess in this scenario, again, generally, one of the key things is to try to rule out whether the patients actually got, or rule out or rule in whether the patients actually got a DVT. So the diagnosis of DVT, as you well know, is made based on clinical presentation, risk factors, and in many cases, a Wells score is used. And Wells score has a scoring system, and I'm not going to preach about Wells score because you guys probably on the front line of actually diagnosing acute DVT would be way better at Wells score than I am, who basically sits on the back seat and look at this patient, you know, beyond the acute DVT. So essentially, in Paul's case, he's got a leg that is swollen. He's got a calf that is swollen, assuming he's got pitting edema, and he doesn't actually have an alternative diagnosis. He's had a major surgery within 4 weeks, so he's tick, probably about 4 boxes. So he's at high risk of a DVT. And in which case, in this scenario, you would proceed straight away to an ultrasound Doppler. So the reason why I've put on this slide is essentially trying to remind us that D-dimer is not necessarily always the first test to do if we are suspicious of DVT. It really depends on the risk stratification of this patient. D-dimer is a very good negative predictive value, but it's otherwise a very, very promiscuous assay. It can be positive in a whole lot number of things, including in a recent total hip replacement, just from a surgery perspective, not necessarily from an acute DVT perspective. However, on the flip side, if Paul was otherwise, you know, did not have any risk factors and had very mild symptoms, then you would consider whether he's sitting on a low risk, and you could potentially proceed to a D-dimer, and then depending on the D-dimer result, proceed to an ultrasound. Okay. And as I've mentioned, D-dimer has a very good negative predictive value. It is good if you want to prove that it is not a PE or DVT, but it's very non-specific. So it can be increased in VTE, it can be increased in a coagulopathy such as DIC, in arterial clots, pregnancy, infection, sepsis, inflammation, as I said, recent surgery, trauma, severe liver renal disease, malignant patient, and any patients with venous malformation. This is a little study. So I'm doing a PhD in global coagulation assay looking at patients with cardiovascular risk factors. And one of the things that we note is that on this cartoon, you'll find that essentially the orange concentrated dot are the normal controls. 500 is essentially our cutoff for D-dimer levels. There is a very, very small population of normal controls that actually have a positive D-dimer despite having no actual signs or symptoms of DVT. And then when you look at the hemodialysis or chronic kidney disease patient, in fact, a lot of them would be above the threshold. So in that sense, what I'm trying to point out is that D-dimer is not the best test in patients, you know, with chronic kidney disease or pregnancy to try to rule in or rule out a DVT or PE, because they could very well be positive. Of course, if it's negative, it may be helpful, but if it's positive, it does not mean that they have a clot. All right. Now, to always make the situation tricky, I'm sure this is something that if any of you do after hours clinic, this probably is not an uncommon presentation because the patient's gone to work all day and then they have decided to come and see you at 8 o'clock, of course, when all the outpatient ultrasound and pathology have closed, and they've come to you and go, I'm short of breath, or I've got a swollen leg. So then in this scenario, what would you do? So I guess I've put up a few options there. You can send the patient to ED, but patients often would tell you, I'm otherwise pretty well. I don't really fancy sitting in emergency for 4 hours, especially not during this COVID times. Do you perform a D-dimer testing, but where do you send it to at 8 p.m.? Or do you give interim parenteral anticoagulant while awaiting an ultrasound tomorrow? I've given this talk before to many GPs, and I find that the answers to this is very varied. I think to a certain extent, it really depends on what your practice does to a certain extent as well. But I think if the patient is of low bleeding risk and you have a high index of suspicion that this patient has a clot, I think it is not unreasonable to give them a stat dose of therapeutic Clexane while waiting for their ultrasound first thing tomorrow morning, rather than actually having to send the patient to emergency. Obviously, if the patient also has concurrent symptoms of pulmonary embolism like chest pain and shortness of breath, then I would personally send the patient to emergency department to be assessed, because currently in Australia, at least, we still admit most of our pulmonary embolism patients. Now, say this patient has had a confirmed DVT on ultrasound. For argument's sake, he's got a left-sided lower limb DVT 4 weeks after a total hip replacement. So then the question is, what would we do with this diagnosis? So often the question surrounds the options of anticoagulation. We are very lucky in the last 10 years that we now have several options of anticoagulation. Compression stockings is one of the very, what should I say? It's one of the things that if you ask 10 different hematologists, probably 5 will give you the same answer and the other 5 will give you a different answer. Not everyone is a true believer of compression stockings. I think compression stockings are good in a sense that if you want to minimize the symptoms, but it doesn't necessarily help with the management of the blood clot. And certainly in some practices, they would prefer not to have compression stockings early on during an acute clot. The third question that is often very important to note as well is the extent of the deep vein thrombosis, particularly if we are talking about a clot that is involving proximal DVT, so a proximal lower limb clot, such as one that's affecting the common femoral vein, then it is very, very important to actually know what the proximal extent of the clot is, because if the patient has iliofemoral DVT, so the patient has iliac vein involvement, I would again strongly recommend that this patient be referred to emergency department for assessment, because in this patient, you would want an acute vascular opinion, because if they present within 5 to 14 days, ideally within 5 days, they could potentially respond very, very well to catheter-directed thrombolysis. Because if you miss this intervention window, potentially these patients are at very, very high risk of severe post-thrombotic syndrome, which could impact on their quality of life. Okay. So the next few slides, we'll be talking about the different types of anticoagulation and how long you would treat a clot for. And then we'll go probably to my next question that I get asked all the time. Doctor, will I get a clot again? And unfortunately, often I like to say I do have a magic ball, but all I can do is quote rather generalized risk, and we'll talk about that in a bit. So as I've alluded to earlier in my talk, it is very important to work out provoked versus unprovoked clots. So we published a few years back now looking at 1,000 patients, and the dotted lines are the provoked clots and the unprovoked clots are in the bold line. And you can see that the patients who have unprovoked clot are certainly at a longer term higher rate of cumulative incidence of recurrence. And again, this stratifies their risk according to the different types of provoking factor, with weak being the minimally provoked factor, intermediate and strong risk factors being least likely to cause a recurrence. The third thing as well is the type of the DVT itself. So if this was an isolated distal deep vein thrombosis, some guidelines would suggest no anticoagulation, just serial monitoring. Other guidelines would suggest 2 weeks, some would suggest 6 weeks, some would suggest 3 months. So again, this really depends. So IDDVT, as common as it is actually one of the least researched topics in clot management. So essentially, it depends on whether the IDDVT is provoked or unprovoked. Generally, if they are not of high bleeding risk and they've had an unprovoked isolated distal deep vein, so below knee DVT, so by that, I mean anything that is below popliteal vein. If there's popliteal vein involvement, that is managed as an above knee DVT by definition, regardless of whether the report says it's below knee or above knee, okay? So if it's below the popliteal vein, generally, if it's unprovoked, I would go for 3 months. If it's provoked, I would do about 4 to 6 weeks, assuming that the provoking factor has been removed, i.e. if their legs were in a cast, the cast has been removed and they're back to normal mobility. If they've had a provoked major VTE, so a proximal DVT, so popliteal and above, and or without a pulmonary embolism, if it's clearly provoked, again, is 3 months. And if it's unprovoked major VTE, guidelines, again, will tell you at least 3 months. But really, how long is a piece of string? And no one really knows the answer to it. So potentially the patient may be treated for a longer duration of time if they are deemed to be high risk. So ongoing malignancy, if they've had recurrent events. Some papers would argue that male is at higher risk. They've got ongoing impaired mobility, and the recurrence risk outweighs the bleeding risk. And the other thing to consider as well is if the patient has had a first unprovoked major VTE, increasingly, guidelines would suggest that this patient should be risk assessed to see whether they can be moved on to long-term anticoagulation at a prophylactic dose. So now back to the case. If I guess in this case, the previous case, it was reasonably straightforward in that Paul, for argument's sake, say he had a popliteal vein DVT in a setting of a total hip replacement, and in this case, I would have given him anticoagulation for 3 months. But what if Paul had presented as an unprovoked VTE? And assuming that, again, it is a popliteal common femoral vein DVT with no involvement of the iliac vein, so it did not cross the, it's all infrainguinal, then the question as well is, does Paul require further testing? I mean, Paul's 75, and he's had an unprovoked clot. It can be quite concerning. I mean, 30% of the clots can happen just like that. And in this 30%, we often just find a cause for 1 to 2% of these people. And unfortunately for the 1 to 2%, often it is a driver, the clot may be the first presentation of an underlying occult malignancy. But the question is, how far do we go to test? Question number 1, do we test for inheritable thrombophilia testing? I would strongly recommend not. So generally, if your patient has an inherited reason or inherited thrombophilia that is deemed to potentially cause a clot, these patients are very, very likely to present at a much younger age, in their 20s, in their 30s, maybe early 40s. But, generally, if they're less than 45, I may consider that, but one would argue that it often does not change management. However, antiphospholipid syndrome is something to be considered if you think that the patient is at risk of that, especially if they've had an unprovoked clot, because it does impact on the management of the patient. If you can't necessarily test lupus anticoagulant if you are on anticoagulation, because it can affect the result of that. So that is something that should be thought about ideally before the patient is commenced on anticoagulation. In terms of malignancy screening, I'll speak about that in a bit in this slide, essentially. So essentially, Mark Carrier is one of the biggest clotters from Canada. And essentially, they looked at a randomized controlled trial of nearly 850 patients, in which they looked at whether they would scan the patient or do not scan the patient. And ultimately, they found that the prevalence of an occult malignancy is low amongst this patient, and that routine screening with CT abdomen and pelvis did not provide any overall survival benefit. So in short, essentially, in unprovoked patient, what I would do is make sure I've taken a clear history from the patient, that they do not have any risk factors for malignancy, they do not have any symptoms of malignancy, For example, if they're a smoker, then you may want to consider a chest X-ray potentially. But otherwise, if they do not have any clear symptoms or clear risk factors for malignancy, then generally, apart from a good clinical assessment of the patient, you do not need to go further. In terms of choice of anticoagulation, anticoagulant, so DOAC, as you probably all know, is now the preferred option over warfarin because it's non-inferior to warfarin with potentially lower risk of bleeding, especially when it involves intracranial hemorrhage. But it is extremely convenient to take, provided the patient is of the correct candidate to take this medication. You do not need a regular blood test. It does not interfere with most of your medication. So it is much simpler to take compared to warfarin. And currently in Australia, only Rivaroxaban and Apixaban is approved for DVT and PE treatment. And as this slide just reminds us that they are a direct 10A inhibitor. And again, this talks about the major outcomes in which they are non-inferior in their efficacy and potentially may confer a better bleeding profile compared to warfarin. I've just put on this slide about the drug characteristics. Essentially, the half-life of Rivaroxaban and Apixaban is anything between 4 to 8 hours, and in some cases longer if they've got renal impairment. So it's very important that your patient has good compliance to the medication, because essentially if they do not take the Xarelto or the Apixaban, the effect of it wears off in several hours compared to warfarin that could potentially be in the system for 3 to 5 days. And as you can see from this chart, there is minimal interaction with most of the medication that the patients are generally on, except for the antifungal and potentially clarithromycin. But otherwise, most antibiotics do not have an interaction with the DOACs. The areas of concern for DOACs remain the lack of reversibility, but this is changing. As you know, dabigatran now does have a reversal agent. Apixaban and Rivaroxaban, they have been TGA approved, but they are incredibly expensive, and there are still ongoing large trials going on to look at the safety data. And I did write here lack of evidence in the following areas, but that's not necessarily the case in cancer patients anymore. Increasingly, we find that as long as your patient is not at particularly high risk of bleeding, i.e. they are not patients who have an intraluminal lesion, such as a gastrointestinal lesion or a genitourinary lesion, or a massive brain mets, a lot of the time, they may potentially be a candidate for DOACs, so particularly Rivaroxaban and Apixaban. And it's something that it's worthwhile thinking about, because 1 to 2 injections a day, and for some patients, the rest of their life is not necessarily a very pleasant thing to have to do. And certainly in antiphospholipid syndrome patient, warfarin remains the main choice of anticoagulation. And we just need to be very careful in patients with brittle renal and liver function, in the elderly population with high falls risk and high bleeding risk population. So generally, I would put outpatients, creatinine clearance over 30, and if they do not have significantly deranged liver function tests, and really we're talking about patients with cirrhosis here, and they have good compliance, or in this case, if they've had previous labile INR control, they could be considered for DOACs. Creatinine clearance of less than 30 is probably something that may or may not be thrown out of the window in future, particularly in the AF sphere, where they have multiple different dosing for anticoagulants. But certainly, it's something that you have to be very, very cautious about, because a lot of them are renally excreted. If they're non-adherent to warfarin, unless if they're going to be adherent to DOACs, it's not going to make any difference. Anyone that's unsafe for warfarin, you really need to think about why they are unsafe for warfarin. Is it because of the comorbidities? Because DOACs, even though it is easy to take, is still a blood thinner. It is still an anticoagulant, okay? Extremes of age and weight. Essentially, the large trials basically look at patients that are between 50 to 120 kilograms. Those with severe liver disease. Metal heart valve, DOAC is a definite no-no. If they are pregnant or lactating, again, DOAC is a definite no-no. Active malignancy, as I say, is contentious. Increasingly, we are using it in this sphere, and in the last 1 to 2 years, there are increasing data to support that they are equally effective to Clexane. And antiphospholipid syndrome and valvular AF are the other areas where they are not approved. And I did briefly mention long-term anticoagulation in some of these patients with a first unprovoked clot to consider them, particularly if they are high risk of recurrence. You can see that I'll just like to draw your attention to the prophylactic dose. Some people talk about aspirin, but aspirin is not a very effective VTE prevention medication at all. Whereas, as you can see, the risk of recurrence is still 3 times that of a DOAC. Whereas a DOAC at a prophylactic dose is much, is either comparable or lower in bleeding risk compared to aspirin. So certainly I would prefer a low dose DOAC over aspirin for VTE prevention, so secondary VTE prevention. In the interest of time, I'll just go through the next few slides quickly. In terms of perioperative management, essentially the rule of the thumb is to look at the renal function and to look at the procedure. If the renal function is relatively normal, so we're talking about a creatinine clearance of, say, over 30 to 50, then you look at the risk of bleeding of the surgery. If they are of a low bleeding risk, generally you could get away with just stopping the medication for anything between 2 to 4 doses. So 2 to 3 drug half-lives is what we say. But if they are high bleeding risk, then you have to consider stopping them at potentially up to 5 days if they have got poor renal function. So it really depends on what their renal function and the type of procedure that needs to be done. In terms of laboratory assays, as you know, there's INR for warfarin, but there is no routine assays for DOACs. Certainly, we can do factor 10A inhibitor for Rivaroxaban and Apixaban, but I would be very cautious in asking for those assays unless if you actually know exactly what question you are asking, because currently we still do not have a what is deemed or defined as a therapeutic range for this patient. But certainly if they're presented to the hospital bleeding or with potential overdose and not knowing which medication they had been on, that's something that we could consider before emergency surgery. If we are not sure when they're taken the medication or if they're in renal failure, again, that's something that we would consider. But it is very important then to actually specify exactly which anti-10A or factor 10A level you would like, because they have different calibration curve. And unless the type of anticoagulant is specified, we do not know which factor 10A to run. So in summary, VTE is a complex chronic disease in which the patient can have a lot of comorbidities following a VTE event. And current guidelines remain guidelines, and essentially you just need a careful clinical, individualized clinical reassessment of this patient, taking also into account discussion with the patient, because you could ultimately potentially be putting the patient on long-term anticoagulation or indefinite anticoagulation. And we do have an interest at the Northern, in which we do have quite a large global coagulation assay laboratory, research laboratory, in which we are looking into trying to find new biomarkers to predict individualized risk of recurrence. And I think that is that. And with that, I'll just like to acknowledge my team of researchers as well. And that's me. All right. Any questions?
Not at this stage, Dr. Lim.
Yeah, sure. All right. I'm just going to have to say, I do have to put my little 13-month-old to bed. So I have to get her to dinner, and I do have to, unfortunately, have to leave the meeting a little bit early. But if there are any questions, I'm happy to be emailed with the questions. All right, and so I'll just hand over to the next speaker.
No worries, thank you.
Thank you.
Okay, can everyone hear me?
Yes, confirming
We can hear you. Yeah.
Okay, good. So my name is Teresa. I'm the next speaker lined up. As Yin suggested, I'm a doctor who is I'm a hematologist who treats malignant hematology, but really I'm a general hematologist. I'm head of clinical hematology at the Northern Health. I treat both malignant and non-malignant disorder, but I do have a special interest in lymphoma, which is closely tied to the topic that I'm going to talk about tonight, which is managing leukocytosis and leukopenia in the community setting. I'm going to try and see whether I could manipulate my screen a bit so I could minimize the camera and also see my slide at the same time. Just bear with me for a second. If I can't do that, then so be it. No, it looks like I can't do that. That's all right, I'll just keep going. So I'll just quickly reiterate the learning objectives of tonight. Abnormal white cell count, as we all know, appears in everyday life when we do an FBE, and is actually a very common finding. And of course, an abnormal white cell count can be either high or low. And a high white cell count or low white cell count has many, many potential causes, some of which are unimportant, some of which can represent a cancer. Most of these cases can actually be safely managed within the community health setting. However, rarely they can represent underlying malignant hematology disorder, which would require a prompt referral to a hematologist. And I hope through this talk tonight, you would be able to further extend your knowledge on how to investigate and manage an abnormal white cell count patient, as well as, more importantly, being able to recognize when you need to promptly contact a hematologist. And some of the information that we provide tonight from me and also the rest of the team would hopefully assist you be able to contact us as Northern Health quickly. We are always available and willing to assist in those circumstances. So what excites a hematologist like me? As this picture shows, the bone marrow and the blood cells, they're all there. I'm not going to bore you by going into a talk about what the bone marrow and the blood cells behave and consist of, but to concentrate on the white cell department of the cell count. And as you can see, they all come from the stem cells, and the main lineages that constitute the white cells are the myeloid lineage and the lymphoid lineage. And that's important to know because it will reflect itself on a section called white cell differential on the full blood count that you see all the time when you order FBE. And the main breakdowns in the full blood differentials would be lymphocytes, which are these cells, neutrophils, basophils, eosinophils, and also monocytes. And you'll see why the white cell differential plays quite an important role when we try to evaluate a abnormal white cell count on an FBE later on with cases. So without further ado, let's look at the first case, Mr. NK. So Mr. NK is an 81-year-old male. He is Caucasian in origin, and he's quite healthy for his age and very active in a social dancing group that he participates every week until COVID hits, and that can't cancel actually. He only has type 2 diabetes as his medical history, and he's on some oral hypoglycemics, which he has been taking for the past 2 years with no change of his medications. He also diligently attends his 6-monthly blood check with his GP. And on the most recent blood test, this is what his GP found. As you can see, on this FBE, the most abnormal finding is the white cell count. It is low. And underneath is the white cell differential that I talked about. And the lowest parameter of it all is the neutrophils. It's down to 0.8. And it's got 3 stars next to it, which means it is very low. And you look at the rest of the full blood count and see that there is also another parameter, the platelet count, that's slightly decreased. Hemoglobin remains normal, and so does the rest of the white cells differential. So at this point, is this a worrying scenario? The answer is it depends, but probably. And I will go on and explain the reason why it depends. The patient's age, ethnicity, and clinical condition is of paramount importance here to consider. And I highlighted clinical condition because if the patient is clinically unwell, then this situation suddenly escalates from probably worrying to become very worrying, and the patient probably needs to be sent to a hospital. Patient's age is another consideration because in a younger patient, such as a baby, we sometimes can find low neutrophils, especially in premature babies. And in very old patients, sometimes they can also, due to a variety of reasons, such as mild myelodysplasia or other medical conditions that they have, has a low neutrophil count. So knowing the age group would help. Ethnicity is also an important consideration, and I'll go into that a little bit later. The other features to consider is that what type of white cell count is low. In this patient's case, the neutrophils is low, which is what constitutes a worrying sign. We don't often see lymphopenia, which is the name for low lymphocytes in the white cell differential. And comparatively, lymphopenia is a less worrying feature if the neutrophils and other white cell counts are normal. And this is generally because lymphocytes are the first white cell type to go down if there is any types of viral infections, reactive causes to a medications or even autoimmune condition, and is rarely a sign of hematological malignancy. And the severity and the duration of the neutropenia is also something that one needs to consider when looking at a low white cell count. I highlighted severity here because the number, how low the neutrophil count hits, would determine whether this is a worrying sign. And in this case, 0.8 is actually considered one of the borderline low red flag sign for neutrophils. So again, that makes this case a little bit complex in terms of whether this is a worrying number or not. I'll go into that a little bit later as well in my subsequent slides. And the final thing to consider is the presence of other cytopenias on the FBE. And in this case, as you can see in the patient, there is mild thrombocytopenia, which is another slightly worrying sign. And if you do see what we call pancytopenia, which is a lowering of all 3 lineage of the cells, red cells, white cells, as well as platelets, then this is a worrying situation, and you should consider contact a clinical hematologist straight away. And finally, what trumps all of the above almost is the presence of worrisome finding of blood film, especially blast on the peripheral blood film and or dysplastic neutrophils, because that is the indication that something is wrong in the bone marrow. Because as my previous picture suggested, all these blood cells have their origins in the bone marrow. And looking at the blood cells on the blood film provides us hematologists with a window of peering what's happening in the bone marrow. And when the bone marrows are full of abnormal cells, they spill out to the blood film. And when these cells start to appear in the peripheral blood, usually something is very wrong with the bone marrow and we want to act straight away. So in this particular gentleman, what's the worst case scenario? Why I say that this situation can potentially be worrying? The number one question or number one concern, I should say, is that will my patient develop febrile neutropenia and sepsis? Because that's the direct clinical consequences of a neutrophil that low, is that the patient may actually become sick from bacterial sepsis. And if that's the case, that is a medical emergency and the patient needs to be sent to emergency department straight away even. The second concern that one would ask in this scenario is, given the neutrophil count is so low and the platelet count is also a little bit borderline, can my patient have a bone marrow disorder? And the answer is maybe. And what type of bone marrow disorder can present like this? Acute leukemia can sometimes present like this, especially if we find abnormal cells floating around on the blood film. Myelodysplasia again can present like the same, very similar as well with that sort of counts. Myelofibrosis or myeloproliferative disorder, which is a different condition where the bone marrow suddenly produces too many white cells and red cells as a start, and in some cases becomes fibrosed after a while. And when the marrow becomes fibrosed, it can no longer produce any normal cells. Hence, these patients can come in with a cytopenic situation, but it's usually a pancytopenia because all the red cells, white cells, and platelets production line will fail together. But rarely they can fail in steps. So you get different degrees of cytopenia at the start. And rarer but possible is other bone marrow failure syndromes such as aplastic anemia or drug-induced bone marrow failure, which is not uncommon in elderly, especially those that's on rheumatoid type of medications or immunosuppressants. The classical one is methotrexate. Finally, there can be second bone marrow infiltration by another type of cancer. In a man of his age, the first primary consideration is prostate cancer, especially if there is such a past medical history, which this patient doesn't. But as you can see, yeah, a lot of potentially serious condition can give this kind of a peripheral blood picture and low white cell count. So therefore, it's not something that you should certainly ignore and click no action required when you see a FBE result like this. What else can it be that's less serious and not related to hematological malignancy? Can this be reactive to virus or infection, either acute or chronic? Or as I mentioned before, drug-induced neutropenia, very common in this age group, especially with rheumatoid drugs, can also be caused by anti-thyroid drugs, antibiotics, and psychotropic drugs. In younger patients, we considered autoimmune neutropenia, and this can be particularly prevalent in someone who has autoimmune tendencies such as systemic lupus erythematosus, rheumatoid arthritis, and there's a condition called cyclical neutropenia, which is very common in middle-aged females, where their neutrophils go up and down, depending on the time period that you measure. Usually they range between 1 and 2 and rarely falls to below 0.8 or lower. And the way to diagnose autoimmune neutropenia is, apart from establish there may be other autoimmune antibodies such as ANA and lupus, is really a diagnosis of exclusion. There used to be a test called anti-neutrophil surface antibodies. It's very hard to do and it's not always accurate. So in recent times, we do not order that anymore. And in some particularly ethnic groups, which is not uncommon in our northern cohort, they may be on special diet or they're vegetarian, which makes them prone to B12 and folate deficiency. And severe B12 deficiency can cause severe cytopenia. And obviously, if they become that cytopenic, they may also develop other neurological symptoms as well, which means that it is urgent now to replace their nutrition. And usually we would embark on an aggressive B12 replacement regime with weekly IM injections if we found out that they do have nutritional cause. Finally, this is where the ethnicity comes in. In certain ethnic groups, such as African, West Indians, Middle Eastern, Greeks, and Arabic population, they can be born with what we call ethnic neutropenia, which means their white cell count is normally a bit lower than what our reference range is on our full blood count analyzers, which are mainly calibrating on a Caucasian population. the classic picture of these people are usually young males, and they're generally well with no signs of infections whatsoever. So the clinical condition of the patient is important. If they're unwell, if they have night sweats, if they start to have mouth ulcers, even if they're of that ethnic city, then their neutropenia needs to be considered seriously, and a hematological malignancy and other causes excluded. This is probably a bit small for you to see because I even have trouble reading it myself here, but it's a list of drugs that can be associated with agranulocytosis. Agranulocytosis is a serious condition where we defined the neutrophils is less than 0.5. And the culprits that's quite famous are anti-thyroid drugs and also some cytotropic drugs such as clozapine. And quite commonly as general practitioners, you would see these people who's on these drugs attending your clinics. So it is important when you see especially isolated neutropenia that's severe to try and take a thorough drug history and see whether any of these would potentially be the cause. But in our particular patient's case, he's on none of these. So to try and differentiate such a long list from one another, we certainly need to do some further history taking and further investigations. And in this case, as I mentioned before, asking the patients a thorough drug history, infection exposure history, as well as performing an examination, looking for signs of mouth ulcers, any signs of infection elsewhere, measure the temperature, and if you have a SATS probe, do a quick SATS observation to see whether the patient's hypoxic, do a blood pressure to make sure they're not in septic shock. That's very important because if any of those signs appear, you should probably call the ambulance and send the patient to the hospital and give us a call as well too, so we can investigate this patient promptly on arrival. If the patient is clinically well, and like in the case of this patient, you can consider further investigations, including a blood film. LDH is a very important hematological test to order because it gives us an indication of whether there is quick cells turnover. And in a lot of cases of aggressive malignancies, hematological malignancies, the LDH would be elevated to the point of 500, 600. We also found that interestingly in B12 and folate deficiency, if they're severely deficient, we often find an elevated LDH as well too. So it's a good screening test for us hematologists, and it's very easy to order. And as mentioned before, viral serologies, inflammatory markers, as well as autoimmune screen may be useful. And also in elderly patients, like in this particular patient's case, my myeloma screen would be helpful, especially I would consider that if there is concurrent anemia as well. So to summarize, what would constitute an immediate hematological referrals? That means you need to get onto the phone and contact us straight away and probably send your patients to emergency. And these are the red flag symptoms. Blasts on blood film, and as you can see, I have shown you a few blasts. Here we hematologists like looking down the microscope, and when we see these cells, we get very excited because we know we need to get the patients into hospital straight away. Agranulocytosis, here is defined as neutrophils less than 0.2, but I would probably be a little bit conservative and say, you know, less than 0.5, you should start contacting us. Any new and severe pancytopenia, such as a hemoglobin less than 100, platelet count of less than 50, and a neutrophil count of less than 1. Anytime the patient is unwell with reported fevers, mouth ulcers, or any signs of active infection is a red flag. And if any of those happen, yeah, as I said, give us a call and send the patients to ED. And I will outline at the end of the talk how to call us promptly. And short of that, there are other things such as myelodysplasias and other hematological conditions that we would still like to see, not immediately, but probably within 1 to 2 weeks of finding out. So these patients would be best to be referred to hematology outpatients promptly, preferably within 1 week of finding out the abnormal results. And the findings of those include dysplastic neutrophils on the blood film. And when we say there is leukoerythroblastic changes, meaning that we find a combination of slightly dysplastic white cells and a nucleated red cells, which are baby red cells on the film, we worry that the bone marrow may start to be struggling. That's usually a sign when the bone marrow is not producing the right combination of cells, and is a red flag for some sort of underlying bone marrow disorder, ranging from myelofibrosis to secondary cancer, to sometimes, very rarely, leukemia can present like that. So if you see the word leukoerythroblastic changes on a blood film, please try and refer to the patients to us ASAP. Again, pancytopenia, but not as severe as what I mentioned in the previous slides. Parameters should be referred to us promptly. And any other symptoms that's non-sepsis, such as B symptoms, unrelenting bone pain, especially nocturnal bone pain, splenomegaly, or any type of lymphadenopathy, we would like to see them as soon as possible. And if we receive the referral, we would usually triage them to within 1 to 2 weeks, they will be seeing a hematologist. Then who are those patients who can be safely observed in the primary care setting with low white cell count then? And here are listed the patients. Firstly, they need to be asymptomatic because, yeah, if they have any signs of infection or suffering from low white cell count, they should be seen by us promptly. So if they're well and their counts are just slightly below the normal measurable range, such as neutrophils between 1.5 and 2, we rarely ever find any clinical significance within that range, and we mostly would choose to observe those patients. So in particular, those patients, there is no need to send a referral to us too promptly. You can probably observe them for a couple of months in the community. And neutrophils between 1.0 to 1.5 is probably safe to be observed in the community as well, at least for the first month or two, to see whether there is any downward trend. If not, and if they stay within this window of 1.0 to 1.5, it is unlikely, even if they have a disorder of the bone marrow, is going to be a very aggressive one. And we can probably observe them in the community for a bit longer. Or if you send us a referral, we'll probably triage them to see them in a couple of months as well. The other safety signs, or green flags, I would call them, is lymphopenia. Rarely indicates any underlying bone marrow disorder in the lack of other symptoms. Also, single lineage cytopenias, unchanged for over 6 months of observation. So if that man only have a platelet count of 140 without a neutropenia, then he would fit in that criteria and can be safely observed. Or if his neutrophil count is 1.0 to 1.5 without thrombocytopenia, he would also fit into that criteria as well. And also sometimes there is a very recent, there is a very clear precipitant, say a recent infection or recent drug exposure. When you talk to the patient, they're recovering from a cold and they've had 2 courses of antibiotics, some of which can cause neutropenia anyway. Then we can afford to observe them in the community for a couple of weeks until they're completely better, repeat the full blood count again and see what happens. And my recommendation would be monthly observation, then if they're stable, every 3 months. And borderline patients, for example, the patient mentioned in this case, and they have a neutrophil count about 1.0, then you would probably want to observe them a bit more closely. So 2 to 3 week, we should repeat the FBE and have a low threshold of hematological referral if you're uncomfortable with the patient. And these are neutrophil counts of around 1 or less than 1 with no blood film changes or symptoms. Bicytopenias, meaning 2 lineage of disorders. And if you find the neutrophils persistently sit at 1, or if there is progressive neutropenia on serial observation, such as, you start at 1.8, you say, okay, I'll watch the patient, and then next time you do it 1.4, and the next time you do it 1.0, then it would probably be prudent to send a referral to us to have a look. What happened in this particular patient in our case is that the GP did choose to observe the patient for a little bit longer, but he didn't wait for very long. So he repeated an FBE again in about 2.5 weeks time and found that the neutrophil count was 0.9. And by that stage, he referred the patient to me. And at the same time, he also, you can see here that there is a blood film comment, and the blood film says red cell morphology is normal, marked neutropenia, and mild thrombocytopenia persists. So there is no blast on the blood film is what I'm trying to highlight here. And I did see the patient promptly and performed a bone marrow biopsy. And as you can see, his neutrophil actually further deteriorated by May to 0.6 and a slight lowering of platelet count as well too, but this is after his bone marrow biopsy, which actually did not show any hematological malignancy, interestingly. So I was a little bit more reassured after the bone marrow biopsy and didn't worry about it. I did see the patient 1 week after receiving the referral, and he remained very well and remained asymptomatic, and in fact was still going to his dance. So but because of the low counts, I did want to do a bone marrow biopsy promptly, and as I said, it did not show any leukemia, and there is not even a convincing evidence of myelodysplasia. Interestingly, when I did a myeloma screen, we found a protein electrophoresis, which shows 3 grams of paraprotein. So I went on and did a series of tests for myeloma, including a skeletal survey, which were all negative. And the bone marrow biopsy, which again would have picked up myeloma, did not show any increase in plasma cells. The other interesting thing is that his ANA is positive. And because of that combination, we think at this stage, he has some sort of immune neutropenia. I cannot exclude a very early myelodysplasia that is not even detectable on bone marrow biopsy, contributing to the cytopenia, the neutropenia. But given that he's clinically well, I decided to observe him with monthly blood tests, and then now he's down to 3 monthly blood tests, and the latest neutrophils has gone back up to 0.8, and he remains clinically stable. But at any stage, if he develops any symptoms, then I would not hesitate to repeat the bone marrow biopsy again. All right, I will move on to case 2 now, Mrs. AN. The clinical scenario of Mrs. AN is slightly different, as you can see from this chest X-ray. So Mrs. AN is 69-year-old, and when we first met her, she is brought in by ambulance into the emergency department. She was short of breath, fevers, and has been confused for 2 days. And this is during the COVID period of time as well too. So access to medical clinics are more sparse, and I suspect Mrs. AN probably has been feeling at home unwell for a couple of days before calling the ambulance. When she arrived, she's febrile at 38.4, and when we did her pulse oximetry, it's 91%, and this is after us putting her on 3 liters oxygen. So she's quite hypoxic, and as you can see on the chest X-ray here, there is diffuse pulmonary infiltrates on both sides of the lungs, and possibly a very, very mild pleural effusion on the left-hand side. She was still alert at the time, but confused. And she does have chest signs with basal self-crackles and scattered wheeze. Interestingly, there are some bruises noted over her legs, and she was anemic when we did a blood gas on her. This is her full blood count, first done in the emergency department. As compared to the last patient, it's quite different. This patient has anemia, which is probably mild. It's not the most worrisome feature, but if you go down the full blood count, platelet count is 20. This is extremely low. And in contrast, the white cell count here is extremely high. So in case 1, I've illustrated a case of extremely low white cell count. This time, this is an extremely high white cell count. And most of these, if you look at the differentials, is classified as monocytes. And neutrophils is slightly high, the rest is normal. Is this worrying? And I don't think I need to illustrate that this is a very worrying situation. Why? Because the patient is sick, and that's paramount. A sick patient with a very abnormal white cell count over 100 is very worrying for a hematological disorder, because yes, white cell counts do go up in sepsis. However, usually the white cell count would only go up by about 2 times or 3 times. So as you can see, normal white cell count, if I go back to the previous slide, is 4 to 11. So we can sometimes see white cell count going up to 30 or even 40 in a septic patients. However, this is talking about 10 times the normal. So there is really nothing that would produce that type of white cell count apart from a hematological disorder. And of course, the presence of biocytopenia as well, especially the platelet count being so low, is the other telltale indication that there is something really, really wrong with the bone marrow. So, this patient is suspect to have leukemia until proven otherwise, I would say, looking at how clinically unwell she is and the numbers. And given that we don't have any previous full blood count to compare, we would assume that this case is acute. However, in some cases, there can be a chronic leukemia, but usually those patients won't be that unwell on presentation, and there needs to be some evidence to show that the white cell count was already high before this presentation. But for this particular patient in case 2, I'm highly suspicious is one of the following: either acute myeloid leukemia, acute promyelocytic leukemia, lymphoblastic leukemia. Sometimes chronic myeloid leukemia, which is subtype, can present with an acute blast crisis that can make them look that sick. But the only other non-leukemic condition that can make them look sick is high-grade lymphoma, such as Burkitt's. Sometimes I have seen diffuse large B-cell lymphoma not presented promptly when they start to affect the whole system, can present that sick as well. Now, there's an interesting thing that we note in the white cell differential of the patient just now, that the highest modality is the monocytes. Why is that so? As you can see here with the picture, one of these cells is a monocyte, the other 4 are blasts. And not being a hematologist, trained hematologist, I don't expect you to tell me which one is the monocyte, which is the blast. That's not the exercise here. But the automatic counters, which is what most of our full blood count white cell differentials are obtained through, can't actually tell the difference when there are too many blasts in the blood. They would start counting them as monocyte, because there are some criteria that they use that can easily get them mixed up between a monocyte and a blast. This is actually a monocyte, and the rest is actually blast, but they do share some similar features in that they have vacuoles, they're quite large, so the machines can get confused. So in this situation, while you're not getting this blast flag on the automatic analyzer, a high monocytes in the white cell differential in someone with a very high white cell count, or even moderately high white cell count, such as 30 and 40, you should be particularly alert that these are may not be real monocytes. They may actually be blasts. So we always have a low threshold of accepting patients with a high monocyte when you refer them to us. Even if it's a monocyte of 5 or 10, we would see them promptly, because we know that this monocyte trap does exist. And to tell the monocytes from a blast, a manual review of blood film by a hematologist is urgently required, and that's why we would like to see the patient in our system as soon as possible. And of course, when Mrs. AN's blood film is reviewed by us, and of course, she presents on the Sunday as well. We found these ugly, ugly blasts on her film. They're not monocytes at all. In fact, when we recounted the film, it's 80% blasts on reclassifications. And when we do more blood tests on her, which includes a coagulation and D-dimer, the D-dimer is markedly elevated. And she also demonstrated the presence of coagulopathy with elevated INR, elevated APTT, and low fibrinogen, which are signs of disseminated intravascular coagulopathy, DIC. Also clinically, she starts to deteriorate with worsening GCS. And we started treating her leukemia within 2 hours of diagnosis of the acute promyelocytic leukemia, because this is an absolute medical emergency. And the treatment is ATRA, which is a vitamin A derivative, which is an oral tablet, as well as traditional cytotoxic chemotherapy. But we don't start this ASAP. The patient can die from disseminated intravascular coagulopathy. And in fact, this is already happening. As we were treating her, we brought her to a CT scan, and it shows a large left occipital infarct that you can see here, and some old hemorrhage as well too. Oh, this is the last slide. And unfortunately for Mrs. AM, even though we started treating her at the Northern Hospital promptly, pretty much as soon as she presents on a Sunday evening, her condition continued to deteriorate neurologically. So by Monday morning, she was intubated and needs to be in ICU. And over the next few days, even though we successfully managed to correct her DIC with lots of blood products and lower her white cell count with chemotherapy, her neurological state did not improve. So whatever neurological assault that she sustained during her presentation on day 1 has affected her. And eventually, yeah, she was palliated because we cannot salvage her neurological function, which is a sad story. Now on to the third case. Third case is one of Miss MB. She is a 67-year-old smoker. She had a lower respiratory tract infection 6 weeks ago, but has told me that she has recovered when she presents. Although she's feeling a bit tired, she's had some oral antibiotics for her chest infection, but has denied any weight loss, night sweats, or bone pain. She also denies any bruising or bleeding. And her medical history includes hypertension, and on examination, there is no abnormal findings, unlike the second case. This is her FBE, still high white cell count, but this time the differential is lymphocytes. And is this worrying? The answer is concerning, but not as worrying as case 2. And the patient appears clinically well. That's the main reason I'm not as worried, apart from tiredness. Also is that, that there are other reactive factors that's present. She's a smoker. She also had the recent infection, which means some of these high white cell counts may be caused by that. And also there is no other cytopenias on her full blood count. And a blood film has already been done in this instance and confirmed that the high white cell count is caused by lymphocytosis and no blast. However, the one thing that bugs me is that reactive leukocytosis is typically between the range of 11 and 30. So as I said before, if the patient has infection, sepsis, we really shouldn't see a white cell count of greater than 30, and hers is more than 35. So maybe there is still something underlying there, but because she's so well, it may be a chronic condition. So at this point in time, I'll go back a bit more general and just quickly say that for basophils, eosinophils, and usually allergic conditions can cause these to be high. For lymphocytes, we can see them in viral infection. Smokers, I can see a lymphocytosis quite commonly. With monocytes, as I mentioned before, watch out for the monocyte traps, but they can be elevated a little bit, usually in the point of about 1 to 1.5 in autoimmune diseases, some sort of infections, and also post-splenectomy. Neutrophils, most commonly elevated white cell count with an infection, and can be drug-induced, bone marrow, chronic inflammation, you know it all. But the key is they should be between 11 to 30 if the cause is going to be reactive. And in this case, I'll go back to the blood film because it says that there is lymphocytosis with many smear cells. We do further testing, which include a flow cytometry, and that confirms that the patients have abnormal flow cytometry profile, and he had a chronic lymphocytic leukemia. But what I want to say generally is when to refer to hematology when a white cell count is high, obviously in the setting of 100 immediately. And if the patient is febrile, confused with blasts on blood film, other significant cytopenias, we take the urgent pathway, which is send the patients to ED and give us a call. Prompt referral, white cell count over 30 with no blasts on blood film, like the lady in case 3. If there is any suspicion of B symptoms, and I've talked about monocyte traps already, and I think any monocytosis that's greater than 2.0 and the eosinophilia of greater than 1 if detected on more than 2 occasions is worth a hematology referral. Also note any basophilia of greater than 0.3 should be referred, and this can be a feature of the chronic myeloid leukemia. Neutrophilia between 11 to 20 and lymphocytosis between 4 to 10 can generally be observed safely in the community, provided the patient is asymptomatic and there's no other cytopenia on FBE. And yeah, as I said before, Mrs. MB has chronic lymphocytic leukemia and she remains on observation for now because she has no other symptoms or features of bulky lymph nodes on her CT. But currently, if she does require treatment, we do have a clinical trial for CLL patients at the Northern, and she will be enrolled in that when treatment is required. So we would very much like to see more chronic lymphocytic leukemia patients at the Northern because we do have the latest treatment available for them in the form of clinical trials, which is not otherwise available via PBS. And lastly, I would like to let you know that if you do need to contact us for any advice, we have a hematology GP hotline available, 8405-2596, and we are available from 9:30 to 3:30 Monday to Friday. And this is operated through our laboratory hematology team in Northern Pathology Victoria, and the call will be picked up by a hematologist or hematology registrar directly. So even if it is a non-urgent thing, you just want to run through it with us to know what further investigation that you want to do, you're welcome to call us because we recognize the waiting list has been long during COVID times, and sometimes it's very difficult to refer a patient to clinic for opinion, and we can help you solve some of the problems by talking to you on the phone. We're more than happy to do so. Obviously, outside these hours, please contact the hematology registrar on call through our switchboard 8405-8000. And Chris, who's coming up after me, will talk about how to make the electronic referrals to us. Thank you.
Okay, thank you very much, Teresa. And thank you, Sonia, and also Madeline for giving Northern Health the opportunity to present at this event this evening. I'm just going to start my slides. Okay, can everyone see those slides?
Yes, confirming.
Christopher, no worries. Thank you.
Fantastic. Okay, I'll rip through this very quickly. I just want to quickly show the GPs how they can refer electronically using their desktop software, whether it's Medical Director or Best Practice or Genie, directly to our haematology clinics and our specialist clinics in general. HealthLink Smart Forms are available in that software, Medical Director, Best Practice, Genie, and MedTech Evolution. If you don't have that software, don't worry, you can still continue to send faxes. But if you do have that software, I just wanted to let you know it is available for you to directly send a referral from your desktop to our specialist clinics. I'm going to focus on Medical Director at this stage. So if you're familiar with MD, this is you're in a patient file here, and on the top right of the screen you can see in the red box it says HealthLink. If you click on that tab, it'll open up where on the left there's a new form tab. If you click on that, it will open up with a suite of the health services in Victoria and other states who you can send a referral to using HealthLink. So you would look for Northern Health down there, and then what happens is that opens up further with a range of our specialist clinics. So you would look for haematology, and you'll see with each of our specialist clinics, it's listed with the name of the head of unit. So in this case, haematology, our head of unit is Dr. Prahlad Ho. It is attention to that particular head of unit, but it gets divvied up to whoever is the most appropriate specialist within that clinic on the day that your patient has an appointment. So once you click on the name of the specialist clinic you want, you go to the top right of the screen where it says continue, and you click on that, and it opens up with a HealthLink Smart form. Now here, whatever is in asterisk is what you need to complete. So in this case, we're looking at the referral period. You need to select 3 months, 6 months, 12 months or whatnot. Feedback requested is already pre-ticked. Whether an interpreter is required, in this case, I've ticked yes. It opens up with a box saying what's the preferred language. I've typed in Hungarian there. And then the reason for the patient referral, dear Dr. Lung, thanks for seeing this patient, and so forth. And you'll notice on the left of the screen, there are some other tabs. So if you want to attach pathology results or imaging reports or whatnot, you click on attachments there on the left. I recommend you click on each of those tabs and provide the specialist clinic with as much information as possible. Now, for example, looking at the medications and warnings tab, you can see here that sulfonylureas is one of the medical warnings or allergies or whatnot. Long-term medications, Ventolin is listed here and so forth. So if you click on preview, you'll get a view of what this referral is going to look like when you send it. This is how we're going to receive it. And then if you click on submit, you'll then get an acknowledgement on your screen, in the top left of the screen, in red text saying this referral was sent and acknowledged on this date and this time. So you know that it's successfully transmitted from your desktop. No need to fax it, no need to print it off. It stays in your clinical record. This is obviously the best practice view. If the steps are identical, it's just a matter of finding the HealthLink forms in best practice. So you're in the patient file there, you click on view, and then towards the bottom of that, HealthLink forms. And then of course you click on new form, and it opens up once again with the different health services. You find Northern Health, and then you find haematology or whichever specialist clinic you need. One tip I'd like to give you is that when you are completing the form, note that Health Pathways, there's a link to Health Pathways just at the bottom of the front page there. Please use that, because that will help guide you through what things you need to include in this referral to ensure it's a successful referral and it can be actioned by Northern Health. By clicking on that link, it opens up directly to Health Pathways Melbourne for an urgent or routine haematology referral, or whatever specialist clinic you happen to be sending a referral to. The relevant link to Health Pathways is there. So I have ripped through that very quickly. If you would like a demonstration, or if you'd like a cheat sheet or whatnot, please send me an email or give me a ring, or speak to Northwestern Melbourne PHN. Your digital health team or practice support team will be able to help you, or Eastern Melbourne PHN, or whichever PHN is your local primary health network. So thank you very much for that, and over to Tracy Webster.
Thank you, everyone. I'm just going to share my screen with you. There you go. Can you see that and hear me?
Yes, we can. Thank you.
Lovely. Thank you. Okay. So I just wanted to give you a little update about what Northern Health are doing about digital transformation. I'll be as quick as I can. So we're undergoing a digital transformation, and partly it's because of our response, as you can see on the right, for COVID-19. And also we launched our Northern Health Strategic Plan 2020 to 2024 as well. And I wanted to explain that our Northern Health specialities, we're actually investing in digital technology to really improve that patient care and that accessibility to care as well. And COVID-19 has been an absolute enabler for, as with many other people, for us to do this as well. So telehealth at Northern Health at the moment consists of telephone, video call, clinical apps as well, which we'll be seeing an increase in as well. Obviously emails and clinical software. We've had an increase of telephone and video call with our social distancing we've had to do in our specialist clinics. We would usually have about 1,000 people come through a day, so that's why we've had the big uptake of telehealth and mostly telephone and video. So we've got some current projects, as you can see, that have been very successful. Our maternity app's just launching. Our ED virtual triage, I don't know if any of you saw it on the news. We've had about over 300 patients, and that actually launched on the 1st of October as well. And GPs can certainly, if you've got a patient with you in your clinic, you can certainly go through onto that and register that patient as well. We've also launched a GP telehealth readiness survey, which has just closed, because we really want to understand how we're going to keep evolving in our digital health. So how can we work best with you, with the GPs and with our patients as well? So that's why we did that survey, because we really want to understand what you've got capacity to do, what you've got the infrastructure to do, and how you'd like to really work with us. That one's been really important for us as well. So we're focusing on call process. That's one of the main things that we've done in telehealth with our video and telephone. So the call process, and this is for outbound calls. So it's basically from the start you make that outbound call through to the final disposition of the call. And the reason we focused on call process in telehealth and getting this right is we didn't want to assume that changing our doctors from seeing 1,000 people a day face to face to telephone or video call, that they would instantly have the skill set, would be able to grab hold of those telehealth standards from RACGP and put them into practice straight away, because that's what you're needing to do if you're embarking on telehealth, is to make sure you're within the standards. So we wanted to make sure that our doctors were really well looked after with this as well. So call process is really important in telehealth. It improves that patient experience, keeps them safe as well. It makes sure those telehealth standards, that we actually implement them for our doctors as well, that we're efficient and that we protect our clinicians as well. And also we protect Northern Health. That was really important to us as well. So as you can see, we developed some resources to help with this implementation. So we did scripting. We then provided some training resources as well. And we also developed some documentation for the patient records, so that when they're talking to the patients over the phone or video call, they can actually pop this into a really easy document, which is mostly tick boxes that they fill out. So we didn't want them to have to memorize the part of the call process or what they've got to do. And you'll see that on the next slide. So on the next slide, this is where we start the call. So with our doctors, we put the rationale as well and information, as well as some hints and tips. So getting them to introduce themselves properly, and our rationale is, getting that greeting right sets that caller up for a positive thing, confirming who's present on that call today for privacy and confidentiality, and just making sure we've got the right people as well. And even when they're doing video call, I don't know if any of you are doing the Health Direct one, we just wanted them to let them know that video can actually have a bit of a lag, so just give that person time to answer as well. We also explained to them that in their standards as well, that they actually have that duty of care, just as if that patient came into the surgery and they're really unwell, or if they're about to collapse. If they've gone onto that video call or they're on the telephone and they're hearing that that person's incredibly unwell, their duty of care is exactly the same. So we'd expect them to render assistance by getting an ambulance to them if that person's on their own and collapsing, or if they've got a carer next to them, getting the carer to call the ambulance, get that 000 there and get them the help they need, and obviously document as well. So that's part of the things that we supported them with, the call process as well. We also got them to set up a call plan as well, just to help the patient know what to do, because for patients it was something new for them as well as for the doctors as well. So with the doctors or the patient, we'd work out what the call was actually for. With the video call, we actually got our doctors to say that it isn't recorded because that's best standard as well, and to gain their consent as well. And they could do it in a really quick sentence to them. And also when they're on video call, to let the patient know what would happen if they got cut off or disconnected, that they would just be phoned back. We wanted to make sure we maintained our patient safety as well. We got them to discuss consent to bill, and limitations is something new that we're working on through at the moment, how we're going to do this. But we certainly got them to talk about billing for Medicare. Is that okay? Because at the moment we're allowed to do verbal consent, which is really good. That's helpful. And we just said to be aware of health literacy when you are discussing things like limitations as well. We reminded them about just keeping your normal process through the body of the call as well. Make your own mini checklist and try and use call control as well, and use empathetic validation. So for instance, if you've got like a 10-15 minute call for that person, as a doctor, you know what you want to get out of that call, but that patient's probably got their own agenda. Once they're with you face to face, you can do cues like you're doing their obs or you're moving around. You can break that when you need to interrupt. It's so much harder on the phone or the video call. So that's why we taught them a bit about call control as well, just so that it can help them give a better patient experience and minimize the doctor's time on the phone or the video call, because we wanted our doctors to get a break between calls as well. So we wanted their calls to be efficient for them as well. So we taught them a bit about empathetic validation. Like, I can see that's really important to you, but we just need to focus on, so being polite, but bringing that patient back as well. It's quite exhausting when you're doing back-to-back calls, as you probably all know. Now you've obviously seen them more face-to-face. It's absolutely exhausting as well. So we wanted to really support our doctors with that. There's a really good, the VHA have just endorsed it by Russell and Kennedy, and I can certainly send it to Madeline. It's a really good webinar about medico-legal, and all of our call process that we use is based on that, but the webinar is absolutely excellent as well. And one of the things they were suggesting as well is to make sure you've got a really good call wrap-up and a disclaimer as well. So letting that patient know what the next steps are as well. That might be that I'll send the script to the pharmacy, or you need to come and pick it up. If you use teach facts, if you've done something like you've taught them something in your consultation with them, it's a really good time to use teach facts. So can you just go through, I've told you about how to do this today, can you just repeat back to me so I know that I've been really clear for you, and getting them to do that as well. And giving them a bit of a disclaimer. So when COVID was hitting, and if we go through our third wave, people were really confused about, could they go to a GP, not go to a GP, could they come to ED, was the Northern shut, and everything that was going on. So just giving them a disclaimer. So, and I know when I go to my GP, they certainly do that as well. And we were teaching our doctors that. So, you know, if you become worse, come back and see us. But if you're really getting worse, I want you to go up to ED. And it's just being really clear with them. We also get our doctors to tick that as well, to show that they've done that as well, just in case there was ever any doubt or call that we had to go back and have a look at the case or anything. And that's it, really. I'm sorry that was so brief, but I know we're over time. Thank you.
Thank you, Tracy, for your presentation. Sorry, I just had some IT issues there. Yeah, thank you, Tracy, and thank you to all the speakers also for presenting today. No, there isn't any questions, Tracy, but there was one question for Teresa, but she's answered it, so it's all good. If there's any other questions, please, if you could just pop it in the question pane, that would be great. We can wait a minute or two. But there's nothing at the moment, so maybe we'll just wait a minute or two, or a few seconds or whatever, because it is a bit late, I guess. Some people have dropped off because it just took a little bit over, so that's okay. If anyone does have any questions, you know, I'm more than happy to perhaps take those questions via email, and we can pass it on to the presenters. So yeah, we can always pass on those questions. yeah, look, it looks like there's no questions. Again, thank you so much for your presentations. It was very informative, so thank you. And we'll hope to see you again. Thank you for all the attendees who attended today too. Thank you.
Thank you very much.
You.
Bye. Bye.
And you can pass the phone number
Bye-bye.
on. Bye.